Hi, good evening, everybody, and a happy 2021. Welcome to tonight's health talk. So, thank you for joining us today. So, I'd like to say happy 2021 again to everybody who has joined us today. So, 2020 has been a very stressful and heavy year for everybody, especially during COVID times. I would think, especially for those who are newly being diagnosed with cancer or seeking treatment during this period, yes, it must have been very difficult for all of you. Okay, so hopefully, we hope 2021 will be a much better year for all of us. Okay, so before we go on, I would like to thank Onco Care Cancer Center today for co-organize today's health talk with us. So my name is Andrew. I'm the Psychosocial Service Manager and a counselor at 365 Cancer Prevention Society. What are we going to talk about today? The topic for today is metastatic colon cancer. Today we're going to know more about what is colon cancer and also learn about the various treatment modality for advanced colon cancer. So we are very honored today to have invited two speakers today. But before I go on, please remember to like and share the video so it can benefit more people to understand the various treatment, especially in terms of advanced colon cancer. So just click on the link, click like and share, as well as there are websites there. You can take a look at some of the information that are provided in the website as well. Yeah, so during the talk, please feel free to ask any questions. If you have feedbacks or comments, please feel free to put in the comments below. So we will also be, there will be a question and answer at the end of the talk as well. Okay, so before I introduce the speaker, for those who have newly joined our Facebook for the first time, please allow me to introduce what is Cancer Prevention Society is all about. So 365 Cancer Prevention Society is a non-profit social service agency in Singapore, where cancer fighters, caregivers find supports in the fight against cancer. It is also a platform where we learn how to cope and prevent cancer as well. The trifold mission of our society are cancer prevention, where we seek to prevent cancer in various means. Cancer fighting, for those who are affiliated with cancer, we walk along them and provide support in their fight against cancer. Also, lastly, cancer education, such as today the Health Talk platform, to learn more about various cancer and also, of course, the various treatment modality. Not forgetting the cancer survivors, fighters or warriors who share with us their cancer journey as well. So what are the services that we have for society that provides? So we have care and support team where the care leaders do visitations to our beneficiaries. So it can be at home, it can be at hospital, or through phone call to provide care and concern. The other thing that the care leaders do also is provide financial assistance for those needy patients or those, in terms of because of COVID, right, we have financial difficulties. They are also the ones who, process the financial application as well. So next, we have counselors such as myself. So we provide emotional and psychological supports. So for example, like worries or anxieties, for uncertainties, treatment outcomes. So we are there to support them as well. And not forgetting about nutritional consult with dietitian as well. So we also conduct health talks, such as one like today. So for Facebook health talks, right, we conduct twice in a month. So one in Mandarin and one in English. So we also have Zoom health talks specifically for our beneficiaries on every weekly basis. But the talks are catered more specifically for cancer warriors and fighters, how to cope during treatments, and maybe how to cope with side effects. Last but not the least, not forgetting our social service centers. Before we move on to the slides, maybe some of you can let me know what, the answer is out. So I wanted to share with you whether you all know where are the three locations of the centers. So the three locations of our centers are Ang Mo Kio, Bukit Panjang, and Clementi. So Clementi being our newer center, the newer center of the three centers, which is very near the Clementi MRT station. So what does the center do? Some of you may ask me. So they conduct programs and activities for our beneficiaries, not just befriending each other. So you also learn like art classes, or in the past we have KTV, but now we cannot have. So exercises as well. So because of COVID, right, nowadays we bring on Zoom, but we're also trying to conduct activities when it allows to have physical activities as well. So recently we have art classes with all the newly joined beneficiaries. So if you're looking into any programs or activities, please feel free to join us as well. Or if you need nutritional advice or counseling, or you need financial assistance, also please feel free to join us. Okay, so if you would like to join us, please refer to the website for more information as well. So without further ado, let us invite the first speaker, Mr. Elio. He's a double cancer survivor. It has been 9 years since his diagnosis and treatment. He now dedicates his time to help others through patient advocacy group and social work. He is also a multiple award winner. He is the co-founder and current president of the Osteotomy Association of Singapore. Let us invite him on board to let him share his cancer journey and how he found out the good work that is done. Hi, Elio.
Hi, thank you, Andrew, for that wonderful introduction.
Hi.
Yes, and thanks to 365 Cancer Prevention Society for inviting me to share my story with everyone. Right. So I'll go straight into it. I was diagnosed with rectal cancer actually in March 2011. On hindsight, I should have sought treatment much earlier because the symptoms were there about a year before I was diagnosed. Initially, it was change in bowel habits, the narrowing of the stool, difficulty in passing motion. But naturally, we thought, it is something that will go away, self-medicated, and didn't really think that it was serious enough to go see a doctor. So it's only when it started bleeding really badly, when I went to pass motion, that I got worried. And then I decided to go see a doctor. So the doctor immediately ordered colonoscopy. And through the colonoscopy, it was discovered that, I had a tumor. And of course, the tumor was sent for biopsy. And then when the results came out, it was diagnosed to be rectal cancer between stage 2 and 3, right? So I was slated for surgery March 25th, 2011. Just before I was going for the surgery, they did a scan and they found another lump in my groin. So they decided to, or I agreed to have it removed during the same operation. So they were removing 2 tumors, one from the anus and one from the groin area. So now, this was sort of a triple whammy because first of all, I found out that I've got rectal cancer, right? Second, because the tumor was so close to the anus, they had to remove the entire anus, and a stoma was created in my abdomen for the passage of stool. And in my case, it had to be a permanent stoma, which means I need to live with it for life, and I have to wear a bag to allow the passage of stool and to collect it, right? So that was the second issue. And the third issue was the tumor that they removed from the groin area was also malignant. That means it was cancerous. And then I had 2 cancers, rectal cancer and testicular cancer. So it's a case of buy one, get one free, right? So anyway, I recovered from the surgery and learning how to manage my stomach. And a couple of weeks later, I started my radiation therapy. So I had to undergo 28 cycles of radiation. Of course, the side effects were, nausea, soreness between the thighs until the skin actually peeled off. It was quite traumatic actually. And after the radiation treatment, I had to go for 8 cycles of chemotherapy. Now, the chemotherapy, they start off with the first day, about 3 hours of intravenous injection of the chemo drug. In my case, it was oxaliplatin and Xeloda. And after that first session, the next 2 weeks is oral pills, all right, huge orange pills that you need to swallow. And then you take a 1 week break, and then you start it all over again. So every cycle is 3 weeks. So of course, chemotherapy has its side effects. Again, nausea, irritability, loss of appetite, diarrhea, and stuff, right? So thankfully, there were medications to help to mitigate these side effects. But one of the things I must tell you that for colorectal cancer chemotherapy, right, you don't lose your hair. So what you see here is fashion, not a result of the chemo. So don't worry about that, right? So I finished my treatment in mid-December 2011, and I started my recovery from the whole thing. And I started doing my exercises, and I went for brisk walks. I did, a few half marathons and a full marathon, all walking. I regained my strength. And then I also did things like a Zumba, line dancing, and a bit of dragon boating. So I tried my best to get back to an active lifestyle. I was very active before my diagnosis. So, but something I realized that when I was diagnosed, I needed information on a lot of things, and it wasn't very easy to find the information or the support. So I decided to make sure that other patients who are newly diagnosed don't have to suffer the same fate. And that's why these days I'm very involved in patient advocacy. I'm with the support groups in both SGH and CGH, and we visit patients, newly diagnosed patients, and give them encouragement and hope. I also volunteer with some other organizations. But one of the things that we did was a few of us got together and founded the Ostomy Association of Singapore. Now, what the association does is it provides emotional and psychosocial support for people living with ostomies, all right, whether it's a urostomy, a colostomy, or an ileostomy. All right, there are some things that the hospitals and other organizations cannot do for the patient, and this is where we step in. And if you want to know more about the organization, you can go and see our Facebook page, or you can visit our website, which is at www.oas.org.sg. Right. So I hope you have benefited from my sharing. And thank you again for 365 Cancer Prevention Society for inviting me. And thank you all for listening. Have a wonderful weekend. And I hand the time back to Andrew.
Hi. So thank you for sharing your experience and of course the good work that you have done so far. I agree with you. There's a lot more work can be done for osteotomy patients. A lot of times, right, the hospitals they do have limited supports. So some of my patients last time in hospital they also say same thing. So I hope the sharing that you have done encourage those cancer warriors or fighters out there that more can be done. No, life is not just about the end, about treatment, and just about cancer. Actually, Mr. Elliot is very active in the community as well as he has climbed mountains. He do cycling, he do mountain biking. So I think he's more active than me actually. So I think he is a model example of a cancer survivor can do much more than what you think. So next, we are very honored to have Dr. Wong Nan Soon. So he'll be sharing with us what is colon cancer and the various treatment modality for colon cancer. So Dr. Wong Nan Soon is a senior consultant medical oncologist at OncoCare Cancer Center. He has more than 15 years in the diagnosis and management of a wide variety of cancers. So without further ado, can we invite Dr. Wong? Hi, Dr. Wong.
Hi. Thank you
I
very
shall pass
much,
the time
Andrew.
over to you. Hi.
Yeah, thank you very much, Andrew, for the kind introduction. And thank you very much to 365 Cancer Prevention Society for the kind invitation to give this talk. Before I start the talk, I'd just like to say thank you to Alil for sharing his very inspiring story of courage and perseverance in his journey to fight cancer. So let me just start by getting the screen up and running. Okay. Right. I hope everyone can see the full screen. Um, yeah. So today we'll be talking about metastatic colon cancer. So this is the outline of my talk where we'll cover some information about epidemiology. We'll talk about the different subtypes of metastatic colon cancer, and the bulk of the talk will be devoted to therapeutics, namely chemotherapy, targeted agents, and the evolving arena of immunotherapy. And not to forget that even in metastatic disease setting, local therapies can be important, and in particular, surgery can be very important in a subset of patients with resectable metastatic colon cancer to the liver or lungs. In the interest of time, I won't be covering radiotherapy and also radioembolization, chemoembolization, for which they are known as TACE or TAR. So this is the anatomy of the colon. And as you can see here, the colon is an organ that's located mostly at the back of the abdomen. It measures about 5 feet in length, and it functions to absorb water and electrolytes and to excrete waste. So cancer can develop in any part of the colon, but the majority of colon cancers are on the left side, and then the 10% of colon cancers can arise on the right, and the rest occur somewhere in the middle in the transverse colon. So an average Singaporean has about a 4% risk of developing colon cancer. It is a disease that is a little bit more common among men, as you can see here from the statistics. It is the commonest cancer in men, and about 1,000 cases annually and 400 odd deaths a year. In women, the incidence and death rate is similar, but there's a slight male preponderance. So coming to metastatic colon cancer, we can see that about 1/4 of patients with colon cancer are already found to have stage 4 or metastatic disease at the time of diagnosis. In other words, the cancer really spread to distant parts of the body, far away from where the colon cancer originated. Even if we focus on stage 2 and stage 3 colon cancer, we can see that over time, as you can see from this look across from year 1 to year 5, by the end of year 5, up to 15% of patients can have a recurrence of colon cancer. And for stage 3, the incidence is even higher. About 1 in 3 cases will suffer a recurrence. In terms of where the recurrence happens, this mostly involves the liver. About 30 to 40% of the time, the liver metastasis can be the first site of recurrence. And sometimes the cancer can go to other parts, such as the lungs, the distant lymph nodes, as well as the peritoneum. So many times we pick up metastatic disease when we follow up our patients after treatment for stage 2 and stage 3 colon cancer. We do blood tests such as the CEA, and then we also do periodic scans. So that can be an early pickup before symptoms occur. However, sometimes colon cancers develop metastatic disease or disease recurrence occurs in between patient visits. So patients can have local symptoms, or if the tumor has recurred more widely, patients can have weight loss, they can feel tired. If the tumor spreads to the lungs, patients can have coughing or breathlessness, and there could be lumps in the body or abdominal distension. So moving on to therapeutics, in the pre-2009 era. So for decades and decades, for about 30 over years, we only had one single drug to treat metastatic colon cancer, and that's 5-fluorouracil. This is a drug which is able to inhibit an enzyme, a key enzyme in the synthesis of DNA. So this inhibition is enhanced by the presence of folinic acid. And on the other hand, this drug can also be converted into a false metabolite which is incorporated into the DNA, causing cell death. Some of the side effects that you have mentioned, that you have heard earlier on from our previous speaker, he had some diarrhea, he had fatigue, and so on. But one of the classic side effects would be what we call hand-foot syndrome or palmoplantar erythrodysesthesia, where there is redness, pain, and tingling in the hands and feet, together with cracking of breakdown of the skin. So there can be other side effects such as low white counts and liver toxicity and diarrhea. So because there was only one drug, there were great efforts made to try and explore how to maximize this single drug. When given directly into the body, what we call a bolus injection, the response rates were low, 10%. The survival was just roughly 1 year. So when combined with folinic acid to enhance the enzyme suppression, the response rates were increased, but survival still remained at about 1 year. And attempts to give it continuously by an infusion pump also didn't have very great success, with survival still below the 1 year ceiling. In the early 2000 era, an oral drug was developed which would allow 5-FU to be generated within the tumor cells preferentially compared to normal cells. And this gave a response rate of about 20%. But again, you can see that it was very hard to break through in terms of the barrier of the 1 year survival. Now, in the year 2000, there were a couple of breakthroughs. The late 1990s, early 2000, this drug called irinotecan was developed from a chemical compound called camptothecin. So the semi-synthetic derivative works as a topoisomerase 1 inhibitor. In other words, it inhibits an enzyme that is critical in DNA unwinding and DNA synthesis. So when cells detect DNA damage, they eventually undergo cell death. And so that's how irinotecan works. The major side effects of this drug would be diarrhea, abdominal cramps, and nausea. There is some element of hair loss if this drug is used, and there's liver inflammation and the potential for very low white blood counts. When combined with 5-fluorouracil, you can see that this drug has a higher response rate than what we could see with 5-fluorouracil alone, with survival starting to reach about the 15 to 16 month type of barrier. At the same time, oxaliplatin also came on board. This is a platinum derivative. What platinum compounds do is that they bind to DNA and they cause strand breaks to occur. And again, when there's DNA damage, cell death occurs in the tumor cells. One of the very well-known side effects of oxaliplatin would be finger toe numbness and cold sensitivity. So we always tell our patients to avoid putting their hands into the fridge and to avoid having cold drinks, as this can trigger an acute cold neuropathy. Other side effects include low white counts and platelets. Some patients get an allergic reaction during infusion, and these drugs can cause liver inflammation as well. So when combined with 5-fluorouracil, response rates are now in the 50% range. Survival again enhanced to about 15 to 16%. And when these two drugs are compared side to side, you can see that there's very little difference which combination to start off with. They both produce similar response rates and survival rates, reaching about 15 to 20 months. So around the 2000 era, targeted agents also started to become introduced. So one of this group of compounds would be drugs that target vascular endothelial growth factors. So tumor cells produce this compound, VEGF, vascular endothelial growth factor, which stimulates angiogenesis, the development of new blood vessels to feed the tumor. So a variety of compounds were developed. Bevacizumab was the first to come to the market, where it binds to the actual growth factor. And subsequently, other compounds came on board, such as aflibercept, which acts as a false receptor. And there are also drugs that directly target the receptors for the VEGF. And there are also drugs that inhibit the intracellular portion of the function of VEGF. So these drugs can cause high blood pressure in patients. They can cause protein loss in the urine. Much less commonly, they can cause serious side effects such as bleeding, wound breakdown, blood clots, and even intestinal perforations. For regorafenib and other oral compounds, these drugs can cause mouth ulcers and hand-foot syndrome over and above what we see with other compounds. So when antivascular agents are used, we can see an enhancement in survival rates and tumor control rates. And here in another study, you can see a modest improvement in the overall survival for the patients. The thing to note about these antivascular, anti-angiogenic agents is that they have to be used for prolonged periods in order for the benefit to be seen. And in this study, it was postulated that the small benefit was because many patients came off the treatment after a short exposure to the drug. So another major chapter in the fight against colon cancer was the understanding of the epidermal growth factor receptor pathway in cancer. So EGFR, so there's a family of receptors that are on the surface of the tumor cells. So EGFR or HER1 functions to transduce signals down into the DNA of the tumor cell, causing tumor cell growth, proliferation, and survival. So steps were taken to actually target this receptor. So the two compounds that are used in clinical practice are cetuximab and panitumumab. So these compounds bind to the receptor on the surface of the tumor cells, disrupting downstream function. But on top of that, in particular for cetuximab, they actually recruit a whole cascade of immune response within the body to fight the cancer. So there's activation of the natural killer cells, the T cells, dendrocytes, and so on. So it's more than just disrupting the function by binding to the receptor, but recruiting host immune response to fight the cancer as well. So side effects for patients on anti-EGFR compounds would include acne, mouth ulcers, diarrhea, and patients can get a severe infusion reaction with cetuximab, for which very close monitoring and pre-medications are required during the use of this drug. So you can see here from a summary of some of the trials that added anti-EGFR compounds to chemotherapy, that survival is now reaching above 20 months. 20 to 25 months survival rates can be seen. In this diagram, in this chart, you can see that over time, with no treatment, survival was only 6 months for advanced colon cancer. But with progressive addition of new breakthrough drugs, we can see that the survival of in patients with metastatic colon cancer in the late 2000 era was approaching 25 months. So there was certainly a cause for celebration, but I think in the past few years, we've seen an explosion in the knowledge in metastatic disease. So turning our attention to the EGFR pathway again, one of the key breakthroughs was the understanding that there is a large proportion of colon cancers that have a mutation in RAS. So this is a downstream messenger. So when this downstream messenger is mutated, efforts to stop the EGFR function by treatment with anti-EGFR agents would be futile, because there's actually persistent firing of signals into the DNA despite treatment. So these are some of the mutations that can be seen in the KRAS gene. So we now understand that up to 55% of metastatic colon cancers can harbor mutations in RAS, making them resistant to anti-EGFR therapy. So you can see here that, for example, in studies to combine an anti-EGFR agent, cetuximab, to chemotherapy, that if it is when there's a mutation present, there's no benefit from addition of cetuximab. Now, this slide is looking at a slightly different concept of left versus right, which I'll explain in a minute. So what you can see here is that besides understanding that mutations occur and we have to test patients for these mutations in order to identify patients who may or may not benefit from treatment, another advance in the past 5 to 10 years was the understanding that colon cancer can actually be divided into right-sided tumors and left-sided tumors, and they have a very different behavior. So in this case, you can see that if we have chemotherapy and a targeted agent, when we use that in right-sided tumors, we see absolutely no difference in survival rates. But when we use it in a left-sided colon cancer, left-sided meaning coming from the descending colon, from the semicolon and rectum, for example, we see an enhancement of survival. So this is again highlighted in this study, which is, I think, very, very informative. One of the key landmark studies that we have published regarding this correlation between left and right and response to targeted agents. So if you focus first on the red box, you can see that if you have a targeted agent called cetuximab, which targets EGFR, that has a great effect on left-sided tumors where there's a remarkable improvement in survival, patients surviving nearly 40 months. But when you use it on the right side, it doesn't work. The tumor patients have a very poor survival. So on the other hand, if we use an anti-angiogenic agent like bevacizumab, the left-right difference is not that marked. It's a small difference. And if you look at the left versus right story, rather than thinking about agents, you can see that in general, right-sided tumors have a poorer survival than left-sided tumors. And if a person has a left-sided tumor, it will be advantageous to use an anti-EGFR agent. Whereas if a patient has a right-sided tumor, then it will be advantageous to start off with an anti-angiogenic agent. So this left-right story, I think, has become something that has gripped the community. And here is another figure showing the impact of left versus right, where intensification of chemotherapy mainly shifts the survival upwards for right-sided tumors, but has very little impact on left-sided tumors. So using sidedness to select treatment has become something that's at the forefront in how we manage patients. So why is that so? And that turns out to be that the development of the colon during at the embryonic stage, the colon actually it comes from both the midgut and the hindgut. Yeah? So and you can see that there are distinct differences between the right side of the colon and the left side, and they have different clinical characteristics. Where right-sided colon cancer tends to have a older onset, is more common in females, it's associated with more aggressive tumor biology, worse prognosis, whereas left-sided tumors, the vast majority of tumors, they are occurring in younger patients, they're more common in males, and they have a better response to anti-EGFR agents. And this can be explained by mutational maps. People have actually mapped out the types of mutations that occur across the colon, and there's a gradual transition from the right to the left, where on the right side there are more mutations, particularly in the BRAF gene. These cells have an unstable genome. On the left side, there's a specific upregulation in the gene called HER2 is more common. Yeah, so we're starting to understand why left-sided colon cancer is different from right-sided. So when patients have progressed on chemotherapy, anti-EGFR therapy, and bevacizumab, there are other later lines of therapy that we can use. So regorafenib was mentioned earlier on when we talked about targeting the vascular endothelial growth factor receptor pathway. There's a modest improvement in survival compared to no treatment. There's also trifluridine, or the brand name is called Lonsurf. Again, modest improvement in survival. And these drugs have a moderate to high level of side effects that require very close monitoring. So another major change in colon cancer developed in the late 2010 sort of era. After 2015, we not only realized that RAS mutations were important and sidedness was important, but there were more mutations that we now routinely look for in our day-to-day clinical practice, because these mutations are highly treatable. So, for example, the BRAF mutation, and then this phenomenon of microsatellite instability allows us to use specific agents, and then changes in the HER2 gene can allow us to use the agents seen in this lower row. So HER2, for example, occurs in only 4% of advanced colon cancer, And what the HER2 gene does is it produces excessive amounts of the HER2 receptor that leads to firing off of signals into the DNA of the cancer cells, and leading to all these bad things that happen in the tumor. And the receptor can be targeted by monoclonal antibodies, pertuzumab, trastuzumab, and also internally with a drug called lepatinib. And these are just a couple of studies that show that these drugs indeed do work. These drugs actually, they have been traditionally used in breast cancer, but having discovered that the same mutation or amplification that can occur in colon cancer, these studies prove that targeting the HER2 pathway does work. So these are the waterfall plots that you can see. So a downward direction shows a shrinking of the tumor, and upward direction shows a growth. You can see that 30% of patients do have a response to anti-HER2 therapy in these two studies. And then one of the latest drugs that has been published is this drug called TDXD. So this is a novel drug that uses an antibody to carry a cytotoxic drug into the tumor cell. So there is almost like a Trojan horse effect. So you can see that in patients who are very heavily pretreated, so long as they overexpress HER2, you can see a very high response rate of 45%. And if we talk about no shrinkage but stabilization of disease as well, then 83% of patients actually enjoyed a control of the tumor and with a very, very durable response. The main thing to look out for this drug is actually a lung inflammation. So up to 5 to 6% of patients can suffer lung inflammation, a percentage of which can be fatal. So there are actually protocols in place to monitor patients carefully and to treat these patients should they develop side effects. Another mutation that's becoming more and more widely thought of is the BRAF mutation. So this is a mutation that we normally see in skin cancers, in melanomas. But we are now identifying 5 to 8% of colon cancers, mostly right-sided. These tumors are aggressive and they require a combination treatment. So when we try to attack one part of the receptor, the presence of a BRAF causes the pathway to remain active. So we have to hit the pathway both from the outside and from the inside as well. So this is a very recently published study in 2019 that showed that both a doublet and triplet therapy to target this pathway can result in responses of 26 to 20%, whereas conventional chemotherapy only gave a response rate of 2%. That means only 2% of patients had shrinkage of the tumor. So there was not only improved shrinkage with targeted therapy compared to chemotherapy, there was also enhanced survival as well. So these targeted therapy, they are actually given orally against BRAF mutation, but they do cause a whole host of side effects. Again, the oncologist has to work very closely with the patients to manage all these side effects. And one peculiar side effect is that patients can develop skin cancers while receiving BRAF therapy. So the treating oncologist has to actually pay very close attention to new skin lesions and work with the dermatologist to identify these problems. So another exciting chapter that is evolving is the use of immunotherapy in metastatic colon cancer. So we have heard a lot about immunotherapy and how it's been a game changer in melanoma, in lung cancers and kidney cancers and so forth. So about 5% of advanced colon cancers are candidates for treatment with immunotherapy. And that's because some of these tumors, they have a problem with mismatch repair proteins. These are proteins that help the tumor cells to repair DNA. And when these proteins are either missing from a germline mutation or inactivated by the environment, then tumors can develop. And these tumors have a high number of mutations and abnormal proteins, which can be potentially identified by immune cells. So here we see how we can identify mismatch repair deficient tumors. So normal cells, they have the protein, they stain brown, and tumor cells lack these, tumor cells that are deficient in these proteins, they do not stain brown. They look a pale color. And additionally, they can also be identified by looking at the patterns of the genes, comparing the normal cells versus tumor cells. So colon cancers that are deficient in mismatch repair proteins, they tend to be more right-sided, they tend to be more aggressive looking. And when we look at them under microscope, we often see immune cells trying to come in to recognize and attack these tumors. So what is the role of immunotherapy in this group of tumors? So there are actually drugs that help to stimulate the tumors, the immune cells. So one drug is called ipilimumab. So what this does is it inhibits CTLA4, which normally acts as a brake to dampen immune cell activity. And we also have a drug called nivolumab. So normally T cells, immune cells can actually recognize tumor cells and destroy them, but because of an interaction between the proteins on the tumor cell and the immune cell is unable to recognize and fight the cancer. So we have drugs that can actually inhibit this interaction, and these drugs help to restore anti-tumor T cell function. So this is a study that was just published years ago that showed that a drug that targets anti-PD-1, so it is a drug that is in the immunotherapy category. So when used in tumors that are having problems with DNA repair, what we call microsatellite high metastatic colon cancer, you can see that the response rates, as you can see in this waterfall plot, is 33%. And what is remarkable about this study is that you can see that there's about a third of patients who continue to have arrest of the tumor. So almost like a cure for these patients with advanced colon cancer, because these patients receive treatment for only 2 years, but the effect seems to carry on even beyond the end of treatment. And with combining two immunotherapy agents together, we can see that there is a response. The 55% response, of course, it's not a randomized study between 1 versus 2 drugs. It's not conclusive, but it is hinting towards that maybe double immunotherapy could be more active. And again, a very, very long duration of tumor control, far exceeding what we can see with chemotherapy and targeted therapy. So I want to end by talking about treatment of liver metastasis, just one slide to say that, sometimes patients, when they're diagnosed with advanced colon cancer, they see that there's the tumor spread into the liver, as you can see in the upper 2 scans. About 80% of patients with liver metastasis from colon cancer, they have unresectable disease. That means that there are too many tumors, too large invasion of blood vessels. And about 20% of patients have resectable disease right from the beginning, a single liver metastasis. So we treat these metastases. For resectable ones, we treat them surgically. We remove them surgically, and we use chemotherapy as well. And we can actually achieve long-term cure for these patients. So even among patients with unresectable looking scans at the beginning, up to 30% of patients can be converted, as you can see here, to a resectable situation where they can then have a 20 to 30% chance of long-term survival. So not all cases of metastatic colon cancers are incurable. So limited liver metastasis, limited lung metastasis can be treated with curative resection and chemotherapy. So in conclusion, I just want to drive home the message that we no longer see metastatic colon cancer as one single disease. There's a left side, there's a right side. There are so many uncommon but very important mutations to identify. So our knowledge of tumor biology has greatly enhanced our optimal use of chemotherapy and targeted agents. We have achieved a breakthrough in survival. So in the 1960s and 70s, talk about 6 months survival, and now with appropriate use of therapy, up to 40 months of survival. Yeah? And in special categories of colon cancer, like those who have a mismatch repair deficient or microsatellite high metastatic colon cancer, we can see a small proportion of them having long-term survival with the use of immunotherapy. And we must always look out for patients who can still be cured despite tumor spread in the lungs and liver through the combined use of surgery, local therapy, chemotherapy. So thank you very much for your kind attention, and I'm ready to answer any questions.
Hi, Dr. Wong. Thank you for sharing the very informative about colon cancer. I hope all of us learn more about colon cancer today, and of course, the various treatment modality that is available for colon cancer. So something I also heard along the way, the immunotherapy as well. So now we will spend the next moment answering some of the questions, whether burning or not questions, whether you have for Dr. Wong. Okay, so maybe we can kickstart some of the earlier question that was asked during the talk. By all means, if you have any questions or comments, right, or you have your own experience, you please feel free to share in the Facebook comment below as well. So the first question for us is, can blood tests detect colon cancer?
Okay, so the most common blood test that we use is called the CEA, and that is detecting tumor protein that's released into the bloodstream. So when we use that to with the, that means a patient already has used that to track. So on the other hand, if we use the as a screening tool, that means to look out for early stage colon cancer, then it becomes very ineffective because many patients with early stage colon cancer do not have circulating CEA that can be detected by blood tests. But I think all that will change in the future when we have more advanced tests to detect circulating tumor DNA. But that's something that's not widely commercially available yet for screening purposes.
Okay, so thank you for answering the question. So I think there was a bit of this disruption during when you answer the questions. So hopefully in the future there's more specific blood tests that can detect colon cancer better in terms of blood tests. So there was a comment given here by one of the participants. So you would like to thank Dr. Wong that you have given a very clear explanation. And it's comforting to know that colon cancer is not always, a death sentence, and that there's more than that. The next question asked by another participant is, where does colon cancer usually spread to?
Yeah, so the liver is the commonest site of spread. So the blood supply of the colon is such that the vast majority will return to the liver first before entering the heart. So the liver, being a very vascular structure, tumor cells are trapped inside, and that's why the liver would be the most common site. But other sites can be involved as well. Typically, the lungs can be affected. The lining of the abdominal cavity, we call that the peritoneum, as well as lymph nodes further out from the colon, such as lymph nodes that are near the great blood vessels at the back of the body. Even lymph nodes in the neck can be affected as well. And rarely we can see colon cancer even spread to bones and brain, but typically those are more for the right-sided tumors.
I see. Okay. So I hope we answer your questions. There's actually another question asked by a participant. They actually asked, what is metastatic? How do we classify metastatic? Or what does this metastatic term refers to?
Yes. So when the colon cancer first develops, it is actually in the innermost layer of the colon. So the colon is like a tube. So when the colon cancer cells start to spread to lymph nodes, we call that stage 3. So stage 1 and stage 2 will be the tumor is confined to the wall of the colon. And then stage 3 is when it spreads to the lymph nodes. And when it goes anywhere beyond that, such as into the liver, into further lymph nodes, that's what we call metastatic disease.
I see. So I hope that was a very clear explanation by Dr. Wong. Okay, next, move on to next questions. Okay, so how can we tell, or what are the symptoms of metastatic colon cancer?
Okay, so it really depends on where the colon cancer spreads to. So many times patients who have tumor spread into the liver, they look well, they feel well, and the blood tests look normal. So it's only when the tumor cells are very large, very extensive, where patients may start to feel abdominal discomfort. They may start to lose weight. They may start to have abdominal swelling from water retention. So it really is site specific. So if tumor cells spread to the lungs, patients can develop coughing and breathlessness. If there's involvement of the bones, they can have bone pain and so on. So, but by and large, we do need to do regular surveillance for patients with early stage colon cancer to look out for any relapse. That's why we use blood tests and scans. But that's for patients with known history of colon cancer. And it's very different from screening the general population who have never had colon cancer before, where a colonoscopy or stool blood tests would be the most appropriate screening tool.
I see. I see. Okay. Thank you for that questions. So there's another question that's closely related to this question as well. So Shuling also asked, what are the symptoms to early discovery of colon cancer?
Yeah, so I think the key thing is screening, because you can imagine that even for stage 4 colon cancer, the disease can remain silent for months and years. Yeah? So all the more for early stage colon cancer, these tumors develop first as benign polyps, and they gradually develop more and more changes, what we call dysplasia, and finally become cancerous. So during this long stage of evolution, they can be picked up by scopes. And so we advocate colonoscopy for well individuals with average risk without family history to go for screening even as early as age 45. And so in the past, 50 years old was the goalpost. We encourage anyone above 50 to go for a colonoscopy to detect cancer at an early stage. And the advantage of a colonoscopy is that you can also do removal of the polyps. So it's not only screening for early cancer, but actually preventing cancers from happening in the first place. So recently, the American Cancer Society has recommended to do colonoscopy even earlier at the age of 45.
I see. Okay. So I hope we have Dr. Wong has answered your questions. Okay. So next question is would I feel pain with advanced colon cancer?
There could be
Not
pain.
sure.
I think some patients with very advanced liver swelling, they may develop this sort of sensation of fullness in the upper part of the abdomen. And that can be very uncomfortable for them, especially if there's pressure on the stomach where they have difficulties with digestion, they feel bloated all the time. Sometimes the tumor can actually spread to lymph nodes at the back of the body where there are a lot of nerves. So they can have back pain, for example, from very extensive lymph node involvement. And pain can also develop from spread of tumor into the bones and into surrounding nerves. But by and large, I think the important thing to understand is that we now have very, very good palliative care services for patients with advanced cancer. So it's not only about therapeutics, but actually paying attention to patients in terms of their symptoms and reassuring them that we can keep them comfortable throughout the journey. So that with appropriate pain medications, even nerve blocks and so on, we can keep patients with advanced colon cancer comfortable right to the end.
That's cool. So there's another comment here. While we know that there are several chemo and targeted therapy available, will these treatments cause depression in patients? And let's say if patients has depression, how do we cope with this aspect?
Yeah, so uh, I think it really depends on at what type of treatment we introduce at which stage. So there are patients who are very symptomatic from advanced cancers, where by introducing treatment, the tumor shrinks and they actually have an improvement in quality of life. They have less pain, they have less tumor burden, and that's a positive thing for them. So on the other hand, if we have treatment where patients have no symptoms, that's where it becomes very challenging. We have to monitor. We actually give treatment holidays for patients. So for patients with advanced colon cancer, there are studies to show that you don't have to give the chemotherapy continuously. There are periods when patients are well, the tumor cells are relatively under control. You can actually manage them with reduction in drug intensity, maintenance therapy with very gentle drugs to help improve the quality of life. Yeah, then ultimately, I think there are situations where we see frank depression, where we may have to engage the help of therapists such as yourself, and we also need to get even psychologists, psychiatrists involved, and then also use medications as well to help with mood. Yeah, so it's a lot of multidisciplinary care where we look into the patient's symptoms, we try to de-escalate treatment whenever possible, and we try to support patients both psychologically and sometimes with the help of some medications.
Okay. So I like Dr. Wong how he mentioned chemo holiday. So there's there's a portion where a lot of cancer patients do take a break, and they can do something in between to whatever they want during the break. So I hope we answer this question. Yeah, probably due to time constraint, we can probably answer one or two more questions. Yeah, if so, there's a question posted in the Facebook. If I'm not in a high risk group and my last colonoscopy is clear, so how frequent should we go for colonoscopy?
Yeah, so it's quite a complicated algorithm actually. So there are actually complex charts and tables. It depends on how good the scope is. So for example, if the bowel preparation is poor, patients have to repeat their colonoscopy at a short interval. If the colonoscopy looks completely clean, that means to say they didn't find any polyps, bowel preparation is very good, then every 5 to 10 years would be sufficient. But if the colonoscopist finds that there's a couple of polyps and these polyps are large, they look abnormal under the microscope, then a repeat scope could be as early as in the next year or within the next 3 years. So we actually refer to very complex tables looking predominantly at how good the view was and what was found. How many polyps, how large they were, how abnormal the polyps look in prescribing an interval for repeat scopes.
Okay. Yeah, so we hope we answer your questions. Yeah, probably one last questions from the floor, not literally the floor, the Facebook participants. Can metastatic cancer also affect young people as well?
Yes, so that's the thing that we are increasingly seeing younger and younger patients develop colon cancer, and that's precisely why there's this move towards earlier screening. Yeah, so the goalpost has been shifted from 50 to 45. So age is no barrier, although typically colon cancer would occur with increasing frequency with age, but unfortunately, gender, age, race, these are all not all not factors that completely guarantee that there's no colon cancer. So the take-home message is that we have to be on the lookout, be aware of symptoms. If there's bleeding, even in a young individual, the possibility of colon cancer still has to be entertained.
Okay, so hope that answer your questions. So yeah, I actually have one last question. Yeah, maybe we can spend a bit of time. If metastatic has occurred in peritoneum, what kind of treatment would you recommend in this scenario, or I think in that situation?
Yeah, so it really depends on how extensive the spread is. So if there's very, very extensive peritoneal disease and the abdomen, all the intestines are completely blocked, we do have to consider that this is a high-risk situation where when we give chemotherapy to try to control the tumor, we may sometimes, in fact, cause perforations and cause harm to the patient. But on the other hand, in carefully selected patients, we can actually give chemotherapy, and thereafter we can actually go in to remove peritoneal nodules to try to achieve long-term control of the tumor. So this is a very complex field, a very controversial field, where certain groups of doctors, they are very highly subspecialized in treating peritoneal disease. They can do very, very big surgeries to try and remove every single nodule within the abdominal cavity through very extensive surgery, and we even sometimes give chemotherapy into the abdominal cavity in that situation.
Okay, so Let us put our hands together and thank you, Dr. Wong, today for the list of questions and sharing with us what is colon cancer and the various treatment modality. Thank you, Dr. Wong.
Most welcome. My pleasure. Yeah. Thank you for the invite and have a great evening, everyone. Yeah.
Okay, and I would also like to thank Mr. Elio again for sharing his cancer journey and the achievements and the good work that he has done in the community settings. So before we end today's health talk, I'd like to share with you what is upcoming in the next health talks. So what is upcoming in the next health talk will be held in February the 20th, 8 p.m. same. So in conjunction to World Cancer Day, we co-organize with National University Cancer Institute of Singapore. Dr. Huang Yiqing will be giving a talk in Mandarin. So does food correlate with causing cancer? So you might have some of the questions, burning questions, in relation to this talk. So please feel free and give the feedback and questions during the talk. And we'll also be giving, she'll be asking some of the questions, and there'll be exciting prize to be given on that day. So we look forward for you to attend the next upcoming health talk. Thank you everybody for joining us for this health talk today. Good night.